next topic of the talk is infective endocarditis, a surgical perspective by Dr. Gregory Crooke, who is a cardiovascular surgeon from Maimonides. Dr. Crooke is an adult and congenital heart surgeon who is a native of Boston area. Dr. Crooke received his MD from Cornell University Medical College in New York City and surgical training at Northwestern, CT surgery training at NYU before receiving a pediatric cardiac surgery and transplant training at the University of Southern California in Los Angeles Children's Hospital. Dr. Crooke serves as the cardiothoracic and trauma surgeon in the United States Air Force as part of the 59th Medical Wing in San Antonio, Texas, retiring honorably at the rank of a major. Thank you for your service, Dr. Crooke. His current surgical interests include complex valve surgery, surgery of the aortic root, aorta arch, and transcatheter valve surgery, adult congenital heart surgery, and coronary revascularization and mechanical cardiac assist. He has held academic appointments at the Einstein College of Medicine, NYU School of Medicine, most recently at Downstate School of Medicine. He's a member of the Society of Thoracic Surgeons, the American College of Surgeons, and the American College of Pediatrics, and also International Society of Heart-Lung Transplantation. Please welcome Dr. Crooke. Thank you.
Thank you, everyone. And I want to thank Tony and the team for inviting me to speak at your meeting. So I'm going to try to give you a little bit of surgeon's insight to a non-neurologic disease, though I think there's incredible crossover between these two. And I'm going to start with a case presentation. It's not really a case presentation, the fact that I'm not going to show you any operative slides or imaging, but it's something that my first 3 months of cardiac surgery training I experienced with a patient that has never left me, and I thought I'd share because it really has changed my approach to endocarditis for the rest of my career. And back in the fall of 1990, again, I've been doing this for about 2.5 months, and I was a first-year fellow. A 37-year-old male came over to a transfer from another hospital in New York to NYU with endocarditis, and I was the receiving fellow on call. He walked down the hall. We put him into a step-down unit. We examined him, and it really was doing quite well. Got him echoed, normal ejection fraction, and severe mitral and aortic valve endocarditis with mild to moderate AI, moderate to severe MR, and visible vegetations. Going over his labs from the other hospital and on admission that night, his BUN and creatinine had been worsening, and there were other signs of worsening perfusion. His microbiology, I didn't have the exact one now, but it was probably a staph or a strep. And I called the attending and I said, you know, this guy is not doing as well as he should be. Let's just get him on the OR schedule for tomorrow. And he said, good idea. I took him to the ICU, put a swan in him, put a balloon pump in him for his worsening MR and worsening perfusion. We went to the operating room 10 o'clock the next morning, and he had an uneventful AVR, MVR. He definitely had endocarditis. There was no extensive abscess. And we put 2 St. Jude's mechanical prostheses. It was a timely operation, and we came off the heart-lung machine easily. There's no adverse events. But unfortunately, post-operatively, on his initial neurocheck, his pupils were widely dilated and unresponsive. And it was quite an overwhelming exam. He had negative doll's eyes, non-arousable despite immediate anesthetic, reversible, and not breathing over the vent. I took him down to CAT scan that afternoon. He had massive intracerebral hemorrhage. His falx cerebri was massively laterally displaced and soon had evidence of brainstem herniation, and he was dead within 4 hours from refractory hypotension and bradycardia. So this affected me and became the beginning of my longstanding interest in endocarditis. So endocarditis, by definition, for those who don't know, is a life-threatening inflammation of the inner lining of the heart's chambers. This lining is called the endocardium. The endocarditis is usually caused by infection, bacteria, or other organisms that get into the bloodstream and attach to the damaged areas of the heart. Bacteria typically land on denuded endothelium. They're caused by denuded endothelium is caused by regurgitant jets. It's usually on the downstream side of valves or opposite of intracardiac shunts, such as residual VSDs. Also, foreign bodies are prone to endocarditis. Prosthetic heart valves are very prone, and they have a kind of a by-time approach with early endocarditis, much higher, much more hard to treat because they haven't been fully incorporated into the tissues of the heart. And this explains the early hazard risk. So foreign bodies, especially heart valves, as well as the opposite of regurgitant jets from other cardiac pathology. Can I get some assistance in advancing the slide? Okay. Yeah, that's fine. Okay. Locations of infective endocarditis, native heart valves, prosthetic heart valves, and other targets in the bloodstream around the heart, including pacemaker defibrillators, ventricular assist devices, Dacron aortic replacements, cardiac patches, and native blood vessels when extremely damaged. These are some pictures of endocarditis. This is a mitral valve that's been explanted with a perforation and large vegetation. This is a surgeon's view of endocarditis with a large vegetation on the anterior leaflet on the atrial or downstream side. This is tricuspid valve endocarditis. You can see how extensively destroyed this is. And again, large vegetations on all three leaflets. And this is a surgeon's view looking down the aorta, the aortic valve. And this is a mechanical aortic valve, and it's Dacron's sewing ring that was infected, and it's been separated from the heart with an abscess. So what is the epidemiology of endocarditis? Well, about 3 to 10 patients per 100,000 patient a year in the population at risk. But in absolute numbers in the United States, 40 to 50,000 new cases per year. So it's a real disease. And the incidence appears to be increasing over time in the United States. And the disease itself has evolved over time, in addition to increasing over time. And it's now 25% healthcare rated. So this is not the endocarditis of previous decades. And again, classic endocarditis was younger and middle-aged patients. Risk factors included congenital heart disease, valvular heart disease, and rheumatic valvular heart disease. It was streptococcus dominans. More contemporary endocarditis, it's older and frailer patients are much more common, and much more comorbidities, making their surgical and medical treatment more challenging. It's 25% of this is healthcare related. Risk factors have changed: immunosuppression, longstanding indwelling catheters and dialysis shunts, prosthetic valves, including a rising incidence in new TAVR valves, infectious IV drug abusers, and cardiac implantable devices on the right side of the heart. And it's more staphylococcal dominant than it used to be. So in terms of perspectives, it's uniformly fatal without treatment. The highest mortality of any valvular heart disease, no matter what cause, with a hospital mortality up to 20% and a one-year mortality of up to 40%. Mortality hasn't changed in 20 years, despite advances in care. This offsetting the advances in care are the worsening patient profiles, the more complexities, the older and frailer patients, and the more and more the healthcare related population. So it's a changing disease. This is a slide of the microbiology, but I just want to point out how much this is gram-positive related. And this is clearly what we see: lots of Staph aureus, lots of virulent strep. Enterococci, we're starting to see a lot of this in the TAVR valve endocarditis, with the other organisms not being nearly as prevalent. So Again, staph and strep are the most common. About 85% of endocarditis is gram-positive like this. And these organisms have a high capacity for biofilm production, means they can latch on and stay on, and they're harder to treat with antibiotics because of their extracellular polysaccharide matrix, which protects them and allows them to be invasive. So how do we make the diagnosis? We use what we call the modified Dukes criteria. And this most commonly uses positive blood cultures and echo or other advanced imaging findings. But they often present with stroke, which will contribute to their diagnostic meeting the Dukes criteria of endocarditis. Supplemental imaging is required for people with continued suspicion, complex prostheses, and for surgical planning. And again, from the European Society of Cardiology, this is a good algorithm for the workup and diagnosis of endocarditis. You have a clinical suspicion, you have a TEE, you make the diagnosis, and then you consider further imaging for treatment or complications or surgical planning. Possible TEE, again, further imaging to cinch or refute the diagnosis. And again, supplemental imaging, which I referred to, and it's very important. TEE is most common, transesophageal echo. When there's a question of the quality of the image with transthoracic echo, when organisms with likely bacterial invasion, prosthetic valves are not well evaluated by transthoracic, or to rule out other valve involvement, even though you've made the diagnosis. CTA, which is a great modality and getting better all the time, gives us information on the anatomy of abscesses, pseudoaneurysms, and fistulas. It's essential for planning surgery or just even sternal reoperation, and gives us the extent and the anatomy of the invasive infection. And PET-CT is also good, especially with TAVR endocarditis or question. It also helps us look at metastatic infections and embolic seeding. As I mentioned before, for the modified Dukes criteria, either 2 major criteria, 1 major and 3 minor criteria, or 5 minor. I'm not going to belittle this because it's very long and boring, but either you meet criteria from surgery where you've got vegetations with organisms in it, which cinches the diagnosis, or it's usually imaging. 2 major criteria would include blood cultures and major imaging here. Again, surgical evidence. Minor criteria, it's much more extensive. I've just taken the opportunity to summarize this. You can go to any medical textbook and learn about the minor criteria. So now talking about its treatment. An endocarditis team approach is essential and is now a class 1 indication by all the cardiology and cardiac surgery societies. It includes a cardiologist, an infectious disease expert, and a cardiac surgeon. And the recommendations are a surgeon who's experienced with valve and complex reconstructions and now requiring experience in transcatheter valve. Okay? But it's also essential, I feel, and they feel, to have other specialists that are excellent for the complications. And I think the most important of these is a stroke team neurologist or a good neurologist, a neurosurgeon if necessary, a nephrologist for all the renal insufficiency and acute renal injury for both the treatments of this as well as immune complexes, and even palliative care for those patients who will not be well served by therapy. So what about the management of endocarditis? And this is kind of a summary slide. So it's obviously the prompt diagnosis and institution of effective medical therapy to reduce the risk of complications, to reduce the development potentially of needing surgery. What about antithrombotic therapy? There is no indication for putting people on blood thinners because you've made the diagnosis. Actually, makes the risks of complications worse. We have to assess the need for removal of any of the right-sided or other implantable devices. And then we have to identify which patients meet indications for valve surgery. And this is very important early on. And we monitor the response to antibiotic therapy, both by levels, as well as documenting resolving bacteremia and adjusting for renal injury. Neurologic monitoring is essential, and neurologic evaluation. And then we monitor the hemodynamics. Are these people going into heart failure? Are they developing shock? Is their CHF getting worse? Are their valves getting worse? Are their murmurs getting worse? Are they progressing on echo or resolving on echo? Is their EKGs, are they progressing towards heart block or conduction abnormalities? Then in follow-up, we can try to confirm the cure after antibiotics or after surgery, and of course, counseling and prevention of recurrent infectious endocarditis. Again, anticoagulation, it's ineffective in preventing emboli. There's no role for that. It increases the risk of hemorrhagic conversion and brain hemorrhage. In patients with hard indications for anticoagulation, and this is very similar to the discussion we just had the locked talk, you should anticoagulate or we have to weigh the relative risks. And we recommend using a lesser anticoagulation strategy. In patients with intracranial hemorrhage and a hard indication for anticoagulation, this poses a very difficult dilemma for the team. So we break the endocarditis down into categories informally: left-sided valvular endocarditis, prosthetic valvular endocarditis, right-sided valvular endocarditis, and those as a subset of all of these infectious or IV drug abuser endocarditis. So how do we choose people who need to have surgery? And my motto has been, since reviewing the literature from the 80s and 90s and ever since, is predict early who will fail late. If they're going to need surgery, figure it out early, then start adjusting your plans for the patient. Timing of surgery and the urgency, well, there's emergent cardiogenic shock. These are people who will not live 24 to 48 hours without surgical intervention. There's urgent, meaning as soon as you can get them ready for the OR within a few days. And then we define early surgery, depending on the guidelines, is during the index hospitalization and prior to the usual completion of 4 to 6 weeks of antibiotic course. Because in the earlier days of this, people were adamant about getting a full course of antibiotics in before surgery. That has not proven to be a benefit and may be of risk. There's no benefit of waiting for a complete course after you've met the indications. In general, the risk goes up if you delay for antibiotic therapy because you have worsening organ dysfunction. And the issues of neurologic safety are important in terms of weighing waiting for surgery versus not waiting for surgery. So indications for surgery, outside of how people list them in the guidelines, I think this is a very good set of indications. Shock from valvular dysfunction. And the persistence of sepsis increases your cardiac output and further magnifies the valvular dysfunction and their inability to meet body demands of delivering blood. Persistent sepsis greater than 5 to 7 days, indication for surgery. Severe valve dysfunction, they're going to be in the operating room sooner or later, so they might as well be sooner. You'll make their lives a lot easier and they'll do better in the long run. Signs of heart failure. Prosthetic valve endocarditis is under here, though it is late prosthetic valve endocarditis without staph or some other resistant organism can benefit from a full treatment of medical therapy to see how they do. Any evidence of invasion of the heart from the valve, abscess, fistulas, conduction dysfunction is an indication for surgery. Recurrent systemic embolization and large mobile vegetations, even without a history of embolization, if they're at risk and even without valvular dysfunction, should be considered for prophylactic removal to prevent embolic phenomena. This is the European Society guidelines. I like it because it also talks about the urgency of surgery. But again, aortic and mitral endocarditis, whether it's prosthetic or native, it's with cardiogenic shock or refractory edema, it's an emergency indication. Severe regurgitation and poor hemodynamics, it's urgent, but it's on its way to becoming emergent. And then the ability to not control an infection is usually an urgent indication. And these kind of parallel what we just talked about. And then prevention of embolism. You've got recurrent systemic emboli, or you've got dysfunction of the valve with a large vegetation at 10 millimeters, they should go to surgery. Isolated large vegetations in by itself is a kind of a decisional call by the team. And this is a comparison of the European guidelines and the US or North American guidelines. and they refer to as early surgery. They don't talk about the urgent emergent, but it still comes to the same categories: shock and heart failure, uncontrolled infection, and embolic presentation. And another comparison of the guidelines, again, they say the same things, they just state it completely differently about resistant organisms. And they do always say independent of completion of a full therapeutic course or initial hospitalization. And I don't think it's worth belaboring these anymore. Right-sided endocarditis, a little bit different and just for completeness here. Since it's a stroke meeting, we're not really talking about this, but the indications are failure to control infection, which is about 90% of them. Recurrent septic pulmonary embolism, we talk about it all the time. It's actually quite rare. In large vegetations with high burden disease, again, with persistent sepsis, it really comes back to failure to control infection. So now coming back to the neurology here, with heart surgeons, it's the heart and brain than everything else. I think this is true for everything. And just to say that nothing demoralizes a cardiac surgery team than a devastating stroke or neurologic injury. We do it through a lot of work to make our patients sicker than better and give them good long-term survival. But with the stroke, you've kind of stolen that all away from the patient, their family, and our team. And it's one of the most devastating complications after coronary bypasses. I know we're not talking about that, but it entails permanent disability, 3 to 6-fold increased risk of mortality, incremental hospital resource consumption, and a longer length of stay. It's a devastating thing. And despite many of the recent advances in cardiac surgery are related to cerebral protection. We talk about cerebral perfusion during circulatory arrest. We talk about cerebral protection mechanisms during TAVR and on bypass. And we even report a lot of our outcomes, especially with aortic arch surgery, as freedom from death and stroke with the Rankin score greater than 3, because we know that we haven't accomplished much if they live, but they've had a significant neurologic deficit. So stroke and heart surgery go hand in hand. Neurologic issues and endocarditis, 15 to 40% of patients with endocarditis have neurologic complications. That's such an impressive number. And the majority present at the time of diagnosis or before. In addition, there's 35 to 60% of patients, depending on how hard you look, have silent emboli of the brain. And strokes, whether it's ischemic or hemorrhagic, are associated with excess mortality for all types of treatment of endocarditis. So how do people have cardiac dysfunction or neurologic dysfunction after heart surgery? Well, the etiologies are widespread, and a lot of this overlaps with some of the discussions we have with the neurologists at the time of evaluating endocarditis patients with cerebral findings. But the etiologies include hypoperfusion, and these are the issues: embolism, whether it's from the vessels, from the heart, or air. But primary CNS pathology can become a problem, and this is the group that we're talking about. In addition, there's a bleeding propensity. When we talked about that patient at the beginning who bled on bypass or during his heart surgery and was dead a few hours later, we give such large doses of heparin to make the heart-lung machine safe. We're talking about 15,000 to 40,000 units initially just to go on the heart-lung machine. That's every day in the cardiac ORs. And we repeat the dose to keep the number adequate. And at the end, we reverse everything with protamine. But massive anticoagulation is every day in heart surgery. And of course, cardiac bypass affects platelet dysfunction and gives you hemodilution of coagulation factors. So there's a lot of bleeding propensity for cardiac surgery. Now, neurologic issues in endocarditis in the time of surgery. Well, it can always be new embolic phenomena. Now, a meticulous surgeon, this doesn't happen very often. We're very, very fastidious about how we excise things and replace things and not have this, but it's always a possibility. More important, ischemic infarct expansion. Even people who do bland infarcts, especially if they're large with underperfusion or edema in the brain afterwards, you can see worsening of their pre-existing deficits. And the worst, of course, is hemorrhagic conversion. Now, what are the risks of these things? They're low after TIAs, they're low after silent cerebral emboli. That's an interesting group of patients. Patients with ischemic strokes and no hemorrhage by CTMR may undergo early surgery Cleveland Clinic uses an informal internal cutoff of 3 centimeters, size of a bland injury, to allow people to go to early heart surgery. But more importantly, intracranial hemorrhage usually delays cardiac surgery by 4 weeks. And of course, patients with poor functional status and/or coma are not offered surgery. Now, there is competing outcomes here, and I think this is part of the importance of discussion and working with your stroke team on our patients. Okay, and our patients with neurologic complications, often the urgency and the life-saving urgency of heart surgery directly conflicts with the ability we want to wait and keep patients away from the operating room for 2 to 4 weeks because of the cerebral complications they've had. So look, mandates a good weighing of what's important here. Often our patients will not survive or have additional complications if you wait for the static waiting period. So the risk of neurologic deterioration versus cardiac death needs to be assessed and discussed between the team. At times, surgery will have to be performed despite a substantial increased risk of neurologic deterioration in order to save the patient's life. So the question is, can surgery wait safely? This is again from the European Society and the recommendations for different types of neurologic findings at the time of neurologic assessment of endocarditis. In a silent embolism or ischemic attacks, you can do surgery without delay. Neurosurgery endovascular therapy is recommended for very large or ruptured intracranial infectious aneurysms. Intracranial hemorrhage generally should be postponed by 1 month if safe to do so. After stroke, with high embolic risk, surgery should be considered as long as coma is absent and hemorrhage has been excluded. And the look for infectious aneurysms is essential for those patients with endocarditis and neurologic symptoms. Going back to cardiac surgery and away from neurology now, the surgical management of endocarditis, the cure is based on the adequacy of resection. You cannot leave infected material behind. Radical debridement is required, not wide margins like cancer surgery, but all infected and necrotic tissues need to be removed. All abscesses unroofed, drained, and debrided and irrigated. Everything needs to be cut back to healthy fibrous tissues and reconstructed as needed, and all foreign materials should be removed. There is little role for a non-sternotomy approach in this day of robotic and minimally invasive surgery. These are often big operations, and when you get in there, they often require better and bigger exposure. So surgical assessment and planning, we confirm the diagnosis, we confirm the indication, and we assess surgical risk and candidacy for surgery. If we haven't already done so, we look at the rest of the valves and other lesions to see if any pacemakers and stuff need to be removed. We get a neuro evaluation, or at least I always get at least a bland CT, if not an MRI, prior to seeing any left-sided endocarditis. Pre-surgical optimizations, making sure you work with your ID person, that you got the appropriate antibiotics on board and the sensitivities are confirmed, as well as optimizing renal, CHF, and heme issues. And then for coronary imaging, we cath if it's not bulky imaging on the aortic valves, otherwise CTA for high-risk caths. And we can admit this people were lower risk clinically and have normal LV function if we think the risk of cath is prohibitive. Timing of surgery needs to be discussed, as well as surgical planning. A lot of these are prosthetic valve endocarditis, there's sternal reentry to consider, and the initials, how are you going to address your cardiac reconstruction, your renal issues, and your bleeding management. So who should care for people with endocarditis? And again, it's a class 1 indication. You should have at a center with a complete team of people to handle infectious endocarditis in the team. And the surgeons should be well trained in this kind of surgery. And patients should be on effective antibiotics. And patients should have adequate planning. These are all class 1 indications. What's in the cardiac surgeon's toolbox? Valve replacement and repair. Aortic valve repair is almost always unheard of, but mitral valves and tricuspid valves can be repaired if you can get the infection out. You need to have reoperative valve experience and TAVR explant experience. TAVR explants carry a 2.2 predicted mortality risk over expected. It's just a huge problem. We're still learning how to do TAVR explants well. You have to be familiar with annular reconstructions, root replacements, vascular reconstructions, use of homograft roots, ventricular septal defect closures, and reconstruction of the annulus and fibrous trigones of the heart. So this is all within the day-to-day use of, doing endocarditis surgery. The Commando procedure, I'm going to show you a 3-minute clip, which is not my own surgery. I downloaded it off the web because I don't typically take a lot of intraoperative videos, but it's for patients with 2-valve endocarditis that's also infected the fibrous core of the heart. And basically what we're going to see is exposing both aortic and mitral valve, excising them. Now you've got a complete missing center of the heart that has to be reconstructed. The mitral valve is fixed. Patches are placed to reconstruct the interfibrous trigone, the aortic root, as well as the dome of the left atrium. The aortic valve is fixed, and then the remaining part is closed. Let's see if we can get this to play. It's just a real quick 3-minute tour. And again, it's not my surgery, though I've done my fair share of these. And this shows opening the ascending aorta on a re-op to expose aortic valve prosthesis, which infected. This is cutting out the aortic valve prosthesis. You can see how junky this area is and how quickly it separates because it's all infected. Of course, with the heart stop, there is a little bit of time consideration here. The aortic valve is out. Now we're opening the left atrium and trimming, or now we're trimming the aortic annulus. We're going to open the left atrium here. This is being done through the dome, so it's right underneath the aortic. Now we're taking out the mitral valve. This is the mitral prosthesis here. And again, we're coming right down to the annular tissues. Fortunately, in mitral valves, the annulus needs to be reconstructed less than the aortic valve. And you can see this. This is the residual mitral annulus. This is called a Commando procedure. It used to be called a Rostand procedure. That shows where we are. Now we're putting sutures back through the mitral annulus. And again, this is about a 3.5 hour operation, spread into about 3 minutes. And we're sizing the mitral valve. Mitral valve has been chosen. Sutures are being placed through the mitral valve. Being lowered into position, secured. Now we're going to go into reconstructing the interfibrous trigone. That's the sewing ring that's not been reconstructed. Now we're using pericardial, autologous, or bovine. This is bovine pericardium to reconstruct the remainder of fibrous trigone of the heart, or fibrous core of the heart, from trigone to trigone, completing the rebuilding that annulus anteriorly. And it also forms the base of the new aortic annulus. And now the aortic valve is being lowered into position. The dome of the left atrium is closed. You can see the aortic valve in position here. The mitral valve's underneath there. And next, the aorta is being closed, completing the operation. So what are the results of cardiac surgery and endocarditis? They're sobering. The 90-day mortality for mitral valve and double valve endocarditis is 15%. And for aortic valve, it's about 7.5%. Even though the aortic valve requires more reconstruction, mitral valve gives us less options, and they tend to be sicker patients. So, but this is at 15% for mitral, 7.5% for aortic. And the 5-year mortality continues to do poorly, with up to 30% of patients gone by 5 years. So it is a very sobering effect despite good medical and surgical therapy. And we see that the mortality varies by age group. The older you are, the less well you do. On that note, I'm going to conclude by saying endocarditis is a lethal valve disease, 100% mortality if untreated, 50% require cardiac surgery for cure, requires a multidisciplinary team for management. Cardiac surgery is complex, and up to 30% will have neurologic complications which affect prognosis, timing, and requires advanced imaging and interventions. I want to say thank you.
Thank you so much, Dr. Crooke, for that amazing talk. That video and surgical techniques are amazing, truly, just to look at this. Because of time delays, anyone has one burning question we need to ask? Otherwise, we can have the question for Dr. Crooke after the break. No? Good. So please stay around for the question session afterwards. Thank you.